Evening, everyone. Myself, Dr. Priyanka, your original guru for the subject OMR. Today, we are here to discuss most important MCQ in NEET MDS 2024. All right. So let's get started. First MCQ that is important for NEET MDS is treatment of infected patient with herpes can lead to infection to the dentist, especially involving fingers, is known as. Alright. Now, this type of questions are direct questions. Alright. There are direct terminologies or direct answers to these kind of questions. So they have given option as herpetic vitello, staphylococcal infection, herpetic gladiotorum, and paronychia. All right. So to know answer for this question, you should be knowing the basic brief about HSV, which is herpes simplex virus. Right. So what is it? Basically, HSV or you can say herpes simplex virus is or belongs to herpes viridae family. All right. And total 8 types of herpes viruses are there, which are pathognomonic in humans. All right. So 8 types of herpes virus are there, which are pathognomonic in humans. All right. So the important types that we are going to study here are HSV1 and HSV2. All right. So HSV1 and HSV2. These are most important types that you should be knowing, right? So basically, HSV1 causes infection above waist. All right. So I am giving you the points. All right, from which you can solve more MCQs based on these topics. All right. So just note it down these points which are very important. Okay. And HSV2 virus causes infection below waist. Below waist. All right. Now, the most common sites that these herpes viruses affect are common sites. This herpes virus affects are oral, genital, and eye. All right. Now, I'm going to give you three terminologies which are very important, which can be asked as a direct MCQs. All right. So we have three terms. First is herpetic keratitis. All right. Second one is herpetic vitello. Third one is herpetic gladiatorum. All right. Just remember these three terms. All right. So, what is herpetic keratitis? It is infection of cornea by HSV. All right. This is infection of cornea. All right. Now, what is herpetic vitello? Now, when dentist treats a patient infected with herpes, all right, and he treats patients with his bare hands, and there are some herpetic infections or vesicles which are there on the lips, all right. So dentist by mistakenly touches those, and the inoculation of viruses, okay, into the dentist's fingers occurs, all right, and that causes the herpetic infection of fingers, all right, herpetic infections of fingers especially in dentists. Alright, this is called as herpetic vitiligo. What is herpetic gladiatora? This is infection of skin, alright, through sports, alright, such as wrestling, such as wrestling, alright. So just remember these three terminologies, and also they can give you this image-based question. They can give you this image and ask what may be the probable diagnosis of this image or the infection. All right. So your answer should be herpetic vitiligo. All right. And of course, they will give you history and what they'll not just give you this image. Okay. So the answer for this question is your herpetic vitiligo. All right. Next question that we have is maxillary sinusitis is checked by fluid level, clouding and fluid level, clouding of antrum, and clouding and bony erosion. All right. Now, basically, what is sinusitis? It is a inflammation of sinus. That was maxillary sinus. All right. Now, what happens in sinusitis? There is inflammation of sinus mucosa due to any allergen, bacteria, or virus. What are the changes that takes place in the sinusitis? All right. So basically, there can be a thickening of sinus mucosa. All right. Thickening of sinus mucosa. Second one, there can be accumulation of secretions. All right. Or there can be complete of opacification of the sinus. All right. These are the three major changes that occurs in sinusitis. Now, how will you check this in the radiographs? All right. So, I have just put the coronal section of coronal section of CBCT. All right. So here, if you are able to appreciate, this is a right maxillary sinus. This is a left maxillary sinus. All right. So right maxillary sinus appears completely normal, completely radiolucent. Basically, what is sinus? It is air cavity. All right. So in radiographs, this air cavity will look as a radiolucent cavity. All right. And if you compare right side with the left, this left sinus is completely radio opaque. All right. So complete opacification has taken place due to sinusitis. All right. Next radiograph I have just put to make you understand. All right. So if you can appreciate, this is basically a sinus, maxillary sinus. All right. Yes. Now, if you compare right sinus with left sinus, all right, there is some radiolucency still left in the right sinus, whereas left sinus is completely radio opaque. All right, left sinus is completely radio opaque. Now, here there is a fluid accumulation that has taken place. All right. Now, this is a sinus. There is a fluid accumulation that has taken place in the right sinus. So, how will it look? It will occupy inferior aspect of the sinus. All right. And it will look as if there is a horizontal or straight line. All right. There is a fluid accumulation or secretion of fluid accumulation in the sinus, which appears as a horizontal or straight line, as shown in the radiograph. All right. Uh, so basically, What I want to tell you is, how will you check sinusitis in the radiograph? By clouding, by you can say after seeing clouding or complete opacification and fluid level. So your answer should be answer B. All right. Now, I have just put up the radiographs which are advised in cases of sinusitis. All right. So there are a set of radiographs for all the sinuses. There are set of radiographs for only maxillary sinuses. All right. So just remember, for radiograph, if you want to check all the sinuses, you can just advise PA projection. Okay. And there are two methods for this PA projection. First is granular projection, normal. And there is a parallel projection, which is a modified version of this PA view. All right. Next is radiographs for maxillary sinuses. We have standard occipital projection. Modified method of standard occipital, Bragma method, and PA Waters method. All right. So just remember, they can ask you radiographs for checking sinusitis. All right. Okay. Next question is, in the radiograph, a thin radiolucent line shows between central and lateral incisor is most probably. Now, this is landmark based question. All right, landmark based. Now, to solve such a type of questions, you should be thorough with the landmarks seen in IUPS, landmarks seen in occlusal radiographs, and landmarks seen in OPGs. All right, so that you can just gain marks through answering this kind of questions. All right, easily. Now, they have just put a arrow. What is this landmark called as? All right. What is this landmark called as? Now, they have given the options as an artifact, nutrient canal, external fistula, and a lamina dura. Okay. Now, uh, we can go by elimination method here. All right. Lamina dura, not the answer. All right. Lamina dura is a radiopaque line surrounding your PDL space. So this is not the answer. External fistula, of course not. External fistula, not the answer. All right. Because there is, you can say no periapical infection, nothing like that. You can see here. All right. In the radiograph, a nutrient canal and an artifact. You can get confused between these two options. All right. But here, if you can see, here also there is a radiolucent line. Here also there is a small radiolucent line. All right. Uh, and here also there you can see these radiolucent line. Okay. So these all are not artifact. These are basically a nutrient canals. All right. A nutrient canals. Now what are these? These are basically a you can say neuro. These nutrient canals carries neurovascular bundle, neurovascular bundles. All right, and they appear as a uniform radiolucent line. All right, running vertically upwards, as seen in this radiograph, running vertically upwards in between central and lateral incisors. All right, or into interdental spaces between the mandibular incisor. Mostly it is seen in the mandibular incisors. All right, mandibular incisors. Uniform in width, uniform in width. All right. Interdental spaces on mandibular incisors, and it runs vertically upwards. Vertically upwards. All right. So this is basically nutrient canal. Next question that we have is white sponge nevus is initiated following mutations in which of the following genes that code for epithelial keratin. All right. Now I classify this question as a little hard question because to remember the disease and which genes are mutated in that particular disease is quite or very difficult. So what you can do is you can make a list of these disease. All right, you can make this list of disease and which genes are mutated because these questions can be asked. All right, it's not that this difficult questions will not be asked, can be asked. So please make a list of these diseases and genes which are mutated in that particular disease. Now here in white sponge nevus, basically mutations occur in genes that codes for epithelial keratin are K4 and K13. Alright, K4 and K13. So your answer for this question is both A and B. Alright. So I'm going to give you two or three more important points. Alright. So that you can cover the questions based on this white sponge nevus. So what is white sponge nevus? This is basically, look at this. This is an image, all right? They can also give you image and ask what may be the probable diagnosis, all right? So, what is white sponge nevus? It is basically a autosomal dominant. These questions can also be asked. It is autosomal dominant disease, all right? It is benign in nature, all right? And clinically, how will it look? It is basically a white lesion, all right, and it will look like a elevated with irregular surface as seen in this. Okay, elevated irregular surface with wrinkled appearance, all right, soft in texture, all right, and you can say most affected site is buccal mucosa, all right. And it may involve extraoral sites. Extraoral sites are involved, which are esophagus, all right, and anogenital mucosa. Anogenital mucosa, all right. Next, it does not entail any symptoms. There is no burning, there is no pain, just this lesion will be there on the buccal mucosa. All right. It may cause aesthetic concern in many patients, but there are no symptoms as such. Does not entail any symptoms. All right. So just remember these points for white sponge nevus. All right. Next question that we have is unilateral distribution of ulcer is seen in herpes simplex infection, varicella zoster infection, cytomegalovirus infection, and Coxsackie infection. And they have just put up the image where you can see this small vesicles on the half of the palate, covering the half of the palate. All right. So there is only one infection which shows unilateral distribution, which is varicella zoster infection. All right, varicella zoster infection. So basically, you can diagnose this varicella zoster infection. You can diagnose this based on clinical history. All right, uh, and you can say on clinical presentation. Okay. Now, main routes of transmission in this herpes zoster infection is basically contact with the infected person. All right, contact with the aerosolized saliva of that infected person. All right, or contact with a vesical fluid from the lesion. All right, vesical fluid from the lesion. Now, patient will give you history of fever. All right, prodromal symptoms will be there. Prodromal symptoms will be there, such as fever, malaise, and pharyngitis. All right. Before, or you can see this prodromal symptoms 24 hours before the lesion, actual lesion appears. All right. 24 hours before actual lesion appears. So you can just ask the history to the patient. You can observe the clinical presentation of the lesion, and then you can diagnose the condition. Basically, this is a self-limiting condition. Uh, you just need to maintain the hydration of the patient and symptomatic relief to that patient. All right. Next question is cellulits in the distal portion of the Stensen's duct or in the parotid duct gland. Okay, is seen or can be diagnosed with the help of which radiograph? So lateral oblique, AP view, puffed PA skull, or all of the above. Now, to identify or you can say to see the silhouette in the radiograph, first of all, you can just, I'm talking about submandibular gland or Watkins duct, you can just advise or use a radiograph, alright, OPG, alright, or you can also advise puffed PA skull. Now, what is this puffed PA skull? Now, when the silolith is situated in the parotid duct, alright, or to be more specific, located in the distal portion of the Stenson's duct, alright. So, what you will do if you can take, if you advise OPG, the structures will overlap and you will not be able to see the silolith. Alright. So, what you will advise is puffed PA view. Now, PA view, you need to ask patient to stand still. Alright. And you just need to ask patient to puff his cheeks, puff up his cheeks like this, so that this duct and the glands get separated from the bone. And in the radiograph, we'll be able to see the stone which is situated in the distal portion of Stenson's duct. All right. So, especially for this portion, all right, or if the silolith is in the parotid gland, to see this silolith, you will advise puffed PA skull view. All right, puffed PA skull view. I have put up this. Yeah. All right, so just remember the distal portion of Stenson's duct was silolith located in the distal portion, and the parotid gland can be seen using puffed PA skull view. All right. Next question is Castleman disease is associated with which chronic multiple ulcer? All right. Castleman disease is associated with which chronic multiple ulcer? Your options are subepithelial bullous disorders, paraneoplastic pemphigus, pemphigus vulgaris, and bullous pemphigoid. Now, this is also direct question. They have directly mentioned in the textbook this Castleman disease is associated with dash dash entity. All right. So the answer for this question is your paraneoplastic pemphigus. All right. So now what is this pemphigus? It is basically a rare blistering disease. Rare blistering disease. All right. Uh, and it is basically a multi-organ disease associated with associated with underlying neoplasm. All right. So what uh, most frequently encounter neoplasm with this pemphigus are non-Hodgkin's lymphoma. Remember the neoplasms which are most frequently noted with this paraneoplastic pemphigus, all right? So non-Hodgkin's lymphoma or chronic leukocytic leukemia, thymoma, or our favorite Castleman disease. All right, just remember these uh, four names. All right, they can ask you the neoplasms associated with paraneoplastic pemphigus, so you should be able to tell the answer. All right. So, what is Castleman disease? Basically, it is a lymphoproliferative disorder. All right, lymphoproliferative disorder. And what happens in this, the lymph nodes in the throughout the body is affected, they get enlarged. All right, and this is basically a neoplasm. Okay, so this was a easy direct question. All right. Next question is also a very direct question. Cytoodontogenic cyst is another name for botryoid odontogenic cyst, Borlean cyst, glandular odontogenic cyst, and nasopalatine canal duct cyst. All right. Now, basically, odontogenic cyst is another name for glandular odontogenic cyst. All right. Now, what is this? Basically, it is a distinct developmental, you can say, developmental cyst, developmental cyst. All right. And it resembles histologically to botryoid odontogenic cyst and mucoepidermoid carcinoma. All right. So histologically, it resembles botryoid odontogenic cyst or mucoepidermoid carcinoma. All right. Now, this cyst is basically seen in middle-aged, you can say, patients. There is no gender predilection, can occur in male, female. Okay. Anterior mandible is most commonly affected. All right. Uh, and there is asymptomatic painless swelling in the jaw. Painless jaw swell. All right. So, Odontogenic cyst is another name for glandular odontogenic cyst. All right. Next question that we have, when using busy light, the fluorescence line, the suspected area shows what kind of changes? Now, to answer this question, you should be able to first know or to know what is busy light basically. All right. So, busy light is basically a oral screening procedure for orally potential malignant disorders. All right, like leukopenia. Say example leukopenia. All right, and this is basically a chair side investigation. Chair side investigation. All right. Now, what we do here is we have this lesion. Say this is a lesion. These are the cells which are affected, alright? So say these are the normal cells and these are the abnormal cells or say dysplastic cells. Okay, now what happens is busy light is just a chemiluminescent light. Okay, chemiluminescent light. So we check this lesion using this chemiluminescent light. What happens is normal cells will completely absorb this light, okay, and impart blue fluorescence. Blue fluorescence. All right. And abnormal cells, or to be more specific, this plastic cells, okay, will reflect light, all right, will reflect light and appear white, will appear white. All right. And why this happens in this plastic cells or abnormal cells? Because of increased nuclear cytoplasmic ratio. Nuclear cytoplasmic ratio. All right. So it reflects light and appear white. All right. And here in normal cells, it absorbs light and imparts new fluorescence. So the answer for this question should be loss of fluorescence with appearing white. All right. So this is basically a busy light. The idea behind busy light. Next question is, which pole of the condyle is most accessible for palpation during mandibular movements? All right. Which pole of the condyle is most accessible for palpation during mandibular movements? Lateral pole, medial pole, posterior pole, circumpolar pole. All right. Now, if this is a condyle, all right, this is your ear. This is your ear. All right. Now, when we palpate our condyle during opening and closing mouth, all right, which pole do you get or which pole is getting palpated here? So this is basically a lateral pole. Lateral pole. All right. So basically, to examine TMJ, we have two methods. First, extraauricular, second, intraauricular. Now, since they have not mentioned here extraauricular or intraauricular, we are going to go with extraauricular one. All right. So, extraauricular, just before triggers of ear, you put your index finger and you check. You open and close mouth, the hole which is getting moved. All right. Or you can say the condyle is moving and the pole which you are palpating here is a lateral pole. All right. So your answer for this question is a lateral pole. All right. So these were most important questions for your NEET MDS 2024 exam. All right. So if you have got any doubts, you can put it in the comment box below. And stay tuned for more such important questions in important subjects coming soon. All right. All right, friends. All the best for your exams and have a good day. Thank you.